This is the third lecture on Chapter 22, GI dysfunction, and we're going to start with Hirschsprung's disease. So Hirschsprung's is also called aganglionic megacolon or congenital aganglionic megacolon because it happens before birth in utero. There's an area in the large intestine with no ganglion cells. The ganglion cells are the nerve fibers which trigger peristalsis. So you can imagine your intestines are pushing stuff through, pushing it through, and then all of a sudden you hit an area where there's no movement. So it's going to build up and you're going to end up with this megacolon, this distended colon. So mechanical obstruction because of this motility issue from the lack of ganglion cells. Diagnosed with can be an X-ray, a barium enema. Then they're going to do a biopsy to go in there and see if there are ganglion cells in that section of the colon, and they'll find out it's not. They can do pressure testing as part of that. And this is what it looks like. So here's your small intestine adds into your large intestine, which, right, your ascending, transverse, descending. And then down here is where we have no ganglion cells. So nothing moves. It gets to here. It's pushing it to here, and then it just stops. So this gets big and distended. What children will have is stooling that's just little ribbons of loose stool that are coming around the edges of this big mass and coming out. So you'll get ribbon-like stool. And here's another picture. Liver, ascending, transverse, descending, and hugely enlarged. And sometimes these kids, if it's not treated, they look very distended. That's the same picture. So how do we treat Hirschsprung's? Well, you cannot make peristalsis in that part of the bowel. There are no nerve cells there. It won't happen. All we can do is take it out. So you have to do surgery. That very distended part of the colon needs to heal, needs to, evacuate that stool and regain some muscle tone. It's been so stretched out for so long, it really loses its muscle tone. So we'll put in a temporary ostomy, let everything get to normal, and then we'll reanastomose, do this pull-through procedure to reconnect. So here's kind of a little drawing. This is the part of colon they had to take out, so they put the colostomy here. And this is called a mucus fistula because it's mucous membrane. So nothing's really coming out of it, but it's moist and, mucous membrane. And then after this has all gotten its muscle tone back, they'll go in and reconnect the two. So it's a temporary colostomy. Vomiting. Anybody with kids knows that children vomit. So some of the things we want to notice when a child has vomiting is it bilious? Is it that green or that yellow that shows it's got bile in it? Or is it not? Sometimes kids swallow a lot of mucus and what they throw up is really just white mucus from a respiratory infection, and it's not a GI issue. Do they have nausea and vomiting together? The treatment, sort of like any other thing that can get you dehydrated, we want to use oral rehydrating solutions. We want to replace water and electrolytes together and then watch for dehydration. How much fluid are they losing? And think about aspiration precautions. If you're vomiting, you can aspirate that and get that down into your lungs, and now you have pneumonia to go along with it. So prevent that. Which leads us right to refluxing. Gastroesophageal reflux. In kids, this is what we usually call it. Reflux or GER. You're used to, in adults, calling it GERD. The D means disease because you've already done some damage to the esophagus. In kids, most of the time, we haven't yet done that damage, and so we just call it GER. So it means we've got contents from the stomach coming up into the esophagus. And usually it's because that sphincter at the bottom of the esophagus is relaxed, it's loose. In infants, it usually is. Some parents will tell you, man, my baby spit up every time they ate. And as long as they're growing and doing fine, it's really not a problem. As they mature, that sphincter will get better control. So who's at most risk for having problems with refluxing? Preterm babies, kids who are neurologically impaired, and if they have some issue that causes delayed gastric emptying. So the stomach just stays full much longer than is typical. The best way to diagnose reflux in a child is a 24-hour pH probe. This is the gold standard for diagnosing. They put down, it's an NG that they don't put, they put it down, I guess NG is the wrong term because they don't go all the way to the stomach. They put it to the lower esophagus and leave it there for 24 hours. And it's a special probe that has a pH monitor on it. So it's measuring what the pH is in the esophagus all the time. And the parents keep a record of when the child eats, when they sleep, when they're laying flat, when they're sitting up. And they're measuring, is that acidic content of the stomach coming back up into the esophagus? So they're measuring the pH because the stomach is acidic and what's in the esophagus shouldn't be. They may also do an upper GI series or put down a scope and do some biopsies to see what's going on there. The management, if the child is growing and has no respiratory symptoms, so they're thriving, there is no treatment. In infants, if they're not growing well or just you have a really concerned parent, you can thicken the feeds. So putting anywhere from a teaspoon to a tablespoon of rice cereal into their formula, that's a teaspoon to a tablespoon per ounce, to make it a little thicker so it doesn't come back up quite so easily. And then, of course, the things like sitting them up for an hour or more after eating. Don't feed them laying down, but have them, in a reclining position, but not flat. With children, let's avoid the foods that cause reflux. There are probably certain things they know when they eat them, they reflux. Things like orange juice or, usual, typical causes. We're going to use the same medical treatment that we do with adults, your H2 receptor antagonists and your proton pump inhibitors. Those H2 receptors, ranitidine is an example, so it reduces the amount of acid in the stomach. So if you do reflux, it's not going to do damage because it's not so acidic. Proton pump inhibitors like lansoprazole, they reduce the acid, but they also increase the tone of that lower esophageal sphincter, and they promote healing. So one is more, your H2 receptors are kind of just preventative, or your proton pump inhibitors can treat it or heal it. At Valley Children's, we use Reglan, which is metoclopramide. We use that a lot. Our book says it's controversial, but you will see it used a lot at Children's because it speeds up gastric emptying. On our delayed kids, that is often their issue, is they just don't have good peristalsis. Their stomach stays full too long. And by decreasing the length of time that their feeding stays in their stomach, they don't reflux. So anyway, you'll see that used a lot at Children's, but our book calls it controversial. Then in severe cases, we're going to do surgery, which is a Nissen fundoplication. So what they do, this is our esophagus here. Here's the stomach, and here's your small intestine, your duodenum. So the sphincter here is the issue. It's too loose. So we're going to take the top of the stomach, which is the fundus, and wrap it around the lower esophagus. So essentially, we've made a tighter sphincter than what their sphincter was doing. Okay, recurrent and functional abdominal pain. The book talks about this, that sometimes we don't know what is going on. This is a kid who they can have intermittent or continuous pain. It's got to be at least once a week for 2 months. So this is kind of a long-term thing. They often call them abdominal migraines, and they can be very painful, like a migraine headache, but in the stomach, and sort of like a migraine. The best thing you can do is figure out what triggers it and avoid those things. So having them keep a good record of when it happens, what was, any preceding events, what made it better, what made it worse, and do the best job we can to avoid them. Appendicitis. At Valley Children's, we do a lot of appendectomies. In fact, I was at a conference there last year, and they said that we are the second most appendectomies in the nation for children's hospitals. There's a children's hospital in Texas that does more than us, and we do the second most amount of appendectomies. And I don't know if that's just because our region covers so many children, or if there's something in our area that we're causing a lot of appendicitis. But anyway, this is surgery to take out the appendix. In kids, we see a lot more ruptured appendix than you do in adults, and we prefer to call it perforated. Rupture kind of brings to mind a balloon that pops and it's just destroyed, and that's not what happens. It perforates. It kind of, a little area pops open, the pressure comes out, and then it will seal back up. So perforated is the term we prefer. But anyway, so kids tend to have vague symptoms until it perforates, and then they develop peritonitis, and they are acutely ill. And the problem is the parent doesn't come in when the kid complains of a stomach ache, because kids get stomach aches, and you don't run to the emergency room every time you have one. So what happens, I'm going to move to our picture here. Here is our small intestine coming into our large intestine, and the appendix is what hangs off here. So it gets inflamed. Usually something plugs it here, and so you have germs start to multiply in here, and as they multiply and enlarge, it gets swollen, and that stretching and pressure decreases the blood flow because the vessels are all being compressed, until an area gets ischemic and pops open and spills out what's in there, and then it will seal back up, and it will actually be fine, except inside your intestines are full of germs. Your peritoneum is sterile, so you have just dumped those germs out into the peritoneum and caused peritonitis. Peritonitis is life-threatening. Your appendix is not what kills you. Peritonitis is what will kill you. So at Children's, when we do an appendectomy, they do it laparoscopically. If open, they would actually do a surgery or a incision, but we do 3 laparoscopic sites. And our surgeons, even though your appendix is down here, they tend to do the 3rd one over here. So the umbilicus, lower, midline, and then they do left lower. So how do they diagnose this? Well, you do look at the WBCs. The kids usually are running a fever. We are much better nowadays with diagnosing it by using ultrasound or CT, and they can actually see that swollen appendix. In the past, a lot of appendectomies were done that they got in there and said, oh, you just have some sort of GI infection, a stomach fluid will go away. Sorry, you didn't need your appendix out. But we didn't know, and we didn't want to wait for possible peritonitis. But now, with better ultrasounds and CTs, we have a lot less of those unnecessary ones. Something to think about. Sudden relief of pain can mean that it's perforated. So that swelling that appendix hurts. When it perforates, they feel better for a moment, but then the peritonitis will set in where they run a high fever and they have extreme pain, and they're rigid and guarding their abdomen.